Hey everyone, this is Lou Powell. I am the lead of PK's API enablement practice globally. And today I'm joined by Ham Pasupuleti with our healthcare vertical. And Ham, give yourself a quick intro.
I'm Ham Pasupuleti. Work in the healthcare vertical. I'm a vice president there and play multiple roles, and one of them being a subject matter expert. So looking forward to this conversation on APIs.
Yeah, so today we want to have a conversation. There's a lot of activity going on in the marketplace around FHIR and around patient data, making patient data accessible to patients. And there's also, as we start looking at the concerns in the marketplace, there seems to be this collision between improving patient experiences through their touch points, through their journey. And now with, of course, all of the things going on with COVID, we're starting to see telemedicine play a big role. So as we start looking at the concerns as the FHIR and meaningful use requirements start to heat up, and companies are starting to look at their response, I'd like to have a conversation, just kind of unpack that and help people understand a little bit better how all of these concerns are going to play together and what they need to be considering as really good next steps. So my first question for you, Ham, is what exactly is FHIR?
FHIR is the next generation interoperability framework, if you may, that tries to leverage the modern web-based technologies to overcome some of the complexities and challenges in the previous, or rather the current standards from HL7, which is the version 2, version 3, and CCDA, or clinical document architecture-based standards. Now, FHIR has an acronym. It stands for Fast Healthcare Interoperability Resources. And from that standpoint, it stands to kind of leverage the HTTP, REST, JSON, XML, and those kinds of schemes in order to, with a focus on implementability. Now, the older standards were kind of, not timely. They were event-driven, batch-driven, more from a back-end perspective to facilitate business-to-business types of communications rather than business-to-consumer type of transactions, if you may, which is what is required today when you talk about patient access to information, to their healthcare information and benefit information across providers and payers. So that's the new paradigm.
So what type? So when you speak about that shift in that the back-end systems type data, those concerns to the patient and the interaction data, what kinds of data are represented currently by the FHIR transactions?
Lou, the FHIR framework actually extends beyond the support of all the types of data that the current standards have. In fact, there's about 4 or 5 different levels, if you may, that they support from a specification perspective, besides the foundational aspects of what the framework payload's got to be, the message construct, etc., the security foundations. When they really come down to real-world concepts, it's about level 3 and level 4, and probably level 5. Concepts that they kind of generally have is addressing administrative items, right? Like a patient, a practitioner, or a clinician, the care team, the organization, the location, things like that. Clinical concepts, which ties into allergies, problem lists, procedures, and diagnosis, and things like that. Diagnostic concepts like lab results or clinical observations of BPE and all the vital signs, lab reports, specimens, right? There is therapeutic types of concepts like medications, prescription requests, and when medications would dispense, and other things like that. Obviously, it also extends itself to genomics and imaging studies. That is on the diagnostic side. And then there is the financial side of things, which probably impacting more the payers, if you may, in this new 21st century regulation, where they need to kind of provide for claims, coverage, benefits, explanation of benefits and costs.
So when we start looking at that customer journey, whether it be a patient journey or a physician journey or a clinician journey, is there a lot of data that providers are going to manage that is really not covered by the current FHIR standards? that they have to now figure out how to make that data accessible.
You're absolutely right. I mean, I think if you really look at the FHIR standard, even though it's pretty exhaustive from a regulation perspective and keeping the focus around patient access to their information, there is a very small set of resources. So FHIR makes its data available in terms of resources, and then the use of it is in terms of profiles. So there's multiple profiles that are being worked on today. There is national levels Argonaut profile and Da Vinci profile, but the FHIR from a clinical perspective for the providers is today is called US Core. It's probably going to be called something else, but it has only about 24 different resources that they want to start with. Now, for a patient, when you talk about exchange of information, with patient being the requestor or the consumer, there is only so much of information that's been provided. But if you really look at the entire journey, which is cross-continuum, whether it would be from acquisition, care, engagement, proactive engagement, from a health maintenance perspective rather than an episodic care treatment perspective, there's a lot more data that the providers produce as a part of their medical record. There's a lot of information that the payers produce as a part of their payment or benefit record. So all of those things need to be kind of used, plus a lot of the attitudinal, behavioral types of consumer preferences information is not in the EHRs, it's in other systems, and all of those things need to be aligned, studied, and insights ought to be kind of derived out of them to promote the next best possible action for the moment that matters.
So the answer I'm hearing is that FHIR is a good set of data that talks about the care and the finances and the information and the actors around the care that's given, the diagnoses and those things. But there's a lot of data that FHIR doesn't give an answer for. So when organizations start looking at a broader solution, there are things that they're going to need to cover that are not necessarily covered by FHIR.
You're absolutely right.
And when we look at the data, one of the big concerns that we have is security. So ONC is now asking for providers to take some additional steps in making that data easily available. Could you speak to that?
As we know, healthcare's always got a lot of different regulations. There is the HIPAA part of it, right? And there is, it's besides the privacy, confidentiality, data at rest, data in motion, and things like that. There is, FHIR also provides to you, as different from Meaningful Use Stage 3 that was at a high level saying, follow the right NIST security framework and things like that. This one is, FHIR has actually defined a framework, or at least prescribed a framework to leverage OAuth 2 and OpenID Connect for authorization authentication.
Yeah.
However, we know that healthcare organizations, the care settings within a healthcare organization is siloed. There's different types of systems. Now with patient access, to allow them to take their record with them across the entire healthcare continuum, essentially you need to have an API mechanism to support an API economy in a federated manner. So there are a lot of those foundational, the security, let's say a framework that has been suggested is not prescriptive in how you want to implement that. And it all starts with looking at this as a practice, looking at this as a trusted exchange framework, or TAFCA is one of those things that is being talked about for B2B transactions. So you need to have a governance infrastructure and things like that, and not just look at FHIR as, hey, it's a set of functions and data that I have to enable just to please my patient. But look at it from the perspective of reusability of that information, not just for your patient, but across your partners, but keeping the patient in the center, right? And so there is a lot more other, and it might as well house FHIR as a type of center of excellence or a type of domain across a broader center of excellence an organization needs to follow from an API perspective.
So is there any question I didn't ask you yet that you think would be really relevant to this conversation that we should cover?
Yeah, I think, when you talked about, FHIR trying to drive a whole bunch of patient access, there is also the experience part of it from a physician, clinician, and things like that. There could be gaps in what FHIR offers, or the other thing is, how is this information blocking aspects? How is that going to impact the market? What is in it for the patient, right? I mean, one is about setting up a standard to, make data liquid, but how is it going to impact the rest of the guys? So I think that's an interesting context, only because we've always known, there is this notion that the patient owns their record, but honestly, they don't have their finger on it,
Yeah.
right? And the custodians are expected to be the healthcare organizations like the payers and the providers. But guess what? They hold on to it and
Yeah.
don't waste it because of a very highly competitive, yet regulated, highly competitive healthcare environment. A provider or hospital or health system organization that holds on to a customer and provides them services would like to have that patient bound within their organization. They really
Yeah.
do not want them to go out somewhere else. And that's coming in the way of all the health information exchange business model, the National Health Information Network, and things like that. So with the new regulations of 21st century, bringing in the information blocking rules and stuff, they're actually creating a different business layer, if you may, another interaction where the consumer of these APIs is truly not the patient. The consumer of these APIs is going to be apps that actually goes, become the consumers of data that is being produced in these different silos, aggregate all of them, and then make it available to the end consumer. So think about it like we are probably going to see a lot of apps like the Mint personal financial management software that aggregates data across banks and investment, brokerage accounts and things like that. Ultimately, to have the consumer truly have their fingers and pulse on their information management.
So when we start looking at, leading segments, when you look at the retail vertical, well, a lot of lessons can be learned from the retail vertical when they started focusing on not necessarily the transactional level of execution of a sale, but looking at the customer journey and how they make their sale and what that customer's experience looks like and what leads to the sale and what activities are they doing before they actually get involved with the purchasing process and looking at that whole ecosystem. Do you see correlations happening today in the healthcare industry?
You're absolutely right. So, there was business models changing, right? If you've seen, let's just say, previously insurance companies were just payers, right? They provided benefit packages, but these days they're starting to see that to ensure loyalty, it's just not that financial transaction relationship that they want to have after an acquisition. And then kind of play this part of rationing, but instead they want to be collaborators with their provider network. So they're starting to offer care management services that otherwise cannot be offered, or which is a gap, right?
Yeah.
From a healthcare provider segment. Similarly, pharmacies like CVS Health and all of these guys, they're starting to, because they exist within 3 miles of 70% of the population, guess what? They have this destination neighborhood health neighborhood health destination model, right? Walgreens and Walmarts and all of them. So we are going to see a lot of new entrants. There's going to be a lot more pressure on the true legacy business model of healthcare. There's going to be consolidations. And then from that standpoint, loyalty is not about financial incentives. Yes, costs have a role to play, but at the end of the day, it's about ensuring that they understand the consumer's attitude and behaviors, and consumer loyalty is going to be driven by the experience that is delivered at the moments that matter for the patient. And they want to be, people are now starting to go meet where the consumer is, where the patient is, rather than asking them to come into their brick and mortar. So that's where we see changes, and FHIR is a start, but there is a lot more that you need to use and liquidify, if you may, as data assets to truly make those connections.
Yeah, and another aspect of that same concept is the ability to access data in real time, where right now most of the medical organizations, healthcare providers that we've worked with, that data is very siloed and it's not capable of interoperating with other systems in real time. Therefore, the insight that a consumer can gain based on activities that are happening happens in 24-hour or 48 or 72-hour timeframes rather than real time. Is that what you're seeing?
Yes, absolutely. And in fact, I think that's how you could extend the current regulation of the prescriptive FHIR framework in order to actually create business use cases to actually use that liquid data to promote a lot more engaging experiences, right?
Yeah.
And produce outcomes not just for your patients and your consumers, but also for a business perspective.
Yes. So
Lou,
looking
I
at,
have some questions for you, though.
yeah, yeah, yeah.
I'm now leading charge on the API practices and things like that. Obviously, I've kind of told you about certain gaps that you see in the market, from the standpoint of gaps in FHIR, if you may. But what else do you see as gaps in the market to deliver consumer experiences? What's your take? What are you seeing from retail and telecom industries that healthcare could potentially learn from?
Yeah, that's a great question. I think the thing that we're seeing the most is this lack of. I mean, what we'll find is that there will be somebody in the organization that will say, we've got to create better consumer experiences, and everyone gets aligned with that, and they say this is worthy of investment. So they go make an IT investment in that, and IT starts out by building these large infrastructure or making these large purchases of software or cloud, and they're not taking that investment and aligning it with the value that can be derived quickly from those real impacts on moments that matter to a consumer. So my first advice to most organizations is make sure that you have a clear understanding of the larger architecture and the long-term vision, and then make sure that your first steps are aligned with the real value that you can start to gain and provide to the organization through those customer engagements. And the things that we're seeing are things like, utilizing cloud for event architecture so that we can get those real-time transactions between systems, API enabling those transactions so that we can make them, we can democratize them and create liquidity of data throughout the organization. So those are the things we're seeing.
So what technology challenges, besides adoption of cloud, do you think institutions are going to face when they want to really implement not just security for FHIR, but security from an API enterprise thinking, right? Systems that to enable patient experiences or physician experiences. That's a huge thing. A lot of folks, when you talk about consumerism, think about patient experiences, but there is a happy physician delivers keeps great patients, right? So physician experience is also a big deal on employee experience. So
I think one of the great things about having an API layer that allows you access to data, I mean, when APIs are done right, APIs create frictionless access to data so that you have self-service where teams can come in and contribute data and pull data out of the system. So that creates this frictionless innovation and delivery of capabilities. With that, it gives you an ability to do something that's been very challenging over the last 20, 30 years, and that is decentralization of authentication and authorization. So putting an APIM layer in the middle of those API transactions and centralizing, of course, through something that's high availability and scaled and has points of presence across the country, but gives you a centralized place to manage, is the patient who they say they are? What mechanism are we going to use when we ask questions to authenticate the patient? And how do we make sure that that is universal across our organization? So that if it's someone in a call center or a clinician or someone else accessing something on behalf of the patient accessing it themselves, or someone that they've delegated to, that we have a singular standardized way of authenticating, authorizing, and ensuring that the information that we're giving is being given with the proper authority and is using proper security to ensure that bad actors aren't interchanging with that data. And I think APIs are a great way to solve that. And I think that some of the cloud services that are available today close a lot of those gaps in a very inexpensive way.
Lou, thank you so much. I really don't have any more questions for you, and I think we should be taking questions with our customers together.
Yeah, Ham, what a great conversation. I appreciate it, and looking forward to many conversations with our customers in the future.